Good evening, everybody. Thanks for joining us this evening. And I can see that a few more are trickling in, so it's great of you to join us, particularly the other side of a bank holiday. Those of you who have been in practice today, I'm sure it's been a busy day, so we're very pleased to have you here with us, and we know your time is precious. We're going to be talking about managing challenging behaviour in primary care. My name's John Dale Skinner, and I'm joined by Catherine Thompson, who's my colleague. We're both medico-legal advisors at the MDU. We're also joined by two colleagues that are currently in the background. So there is a colleague called Cam Nat, who's our marketing executive, and she is there to deal with any technical issues that might arise during the webinar. So please do put that in the Q&A. If you are having any issues, Cam will deal with those. And then we also have Kate Muller, who is from our sales team, and she'll be talking briefly at the end of the webinar about the MDU's group care scheme. Okay, so let's move on to our first slide. Oh, and there's one more thing, because I know this is always a question that I'm asked about certificates. So before we get started, there will be a certificate which will be emailed to you after the webinar. All right. So let's move on to the next slide. These are the three questions that we're going to answer today. And we're starting with the NHS Zero Tolerance campaign and asking the question, where do I stand? So as a GP, as a salaried GP or a partner or as a practice manager, where do you stand with that? And Catherine's going to talk a bit more about that. I think that's really important to start off with that, because your welfare and the welfare of your colleagues is important when we're considering challenging behaviour. You need to be working in safe spaces, and also you want your colleagues, if you're a manager, if you're a partner, you want your employees to want to come to work and feel that they're comfortable, they're not going to be threatened by patients, and that there is some sort of procedure in the background if there is challenging behaviour. And then we're going to talk about two case studies, which we hope you're going to find interesting. And then after those two things, I will talk about when we should challenge behaviour, so when we should call it out, and thinking about what constitutes unreasonable behaviour. And then also, if you are getting to the point where you're thinking we need to end the professional relationship with a patient, how do we protect your interests in that decision making? So those are the three things that we want you to be able to take home with you tonight, and hopefully apply to your own practice. And if you're already doing the things, then that's fantastic. So I think the next slide is Catherine's slide, so I'm going to hand over to Catherine. Let me just find that. Over to you, Catherine.
Thanks very much. So we see sometimes in the media reports of incidents in GP surgeries and also occasionally in hospitals, but when these things happen in primary care, they often make the headlines. And this is just a snapshot from a BBC News report. This was actually in 2020. This was quite clearly a really serious incident. So there was an attack at a GP surgery which resulted in 5 people being injured. Some of those were staff, and I understand some were patients in the waiting area. And this is the sort of thing that the NHS has in mind when it talks about the zero tolerance approach to poor behaviour and violence, and why it's important to try to manage patient behaviour, because it's clearly unacceptable for events like this to happen in the GP surgery. This is the generic poster that you can download from the NHS website to put in your own practice, which basically says that there is a zero tolerance approach. And it's an interesting thing, if you Google NHS Zero Tolerance Policy, you will see dozens and dozens of surgeries who have their own mention of their zero tolerance policy. And many, many GP surgeries include reference to this, both in their waiting rooms with the use of posters like this one, and on their practice websites. And it's a clear indication that poor behavior isn't expected or tolerated, and that action can and will be taken. So the zero tolerance policy first came formally into being in October 2018, and it was introduced by the Department of Health and Social Care when they announced their first ever NHS violence reduction strategy. The purpose of that strategy was to try to provide a framework for NHS staff to handle issues, serious issues of violence. And the strategy set out an intention to produce increased scrutiny of violent and events that were unacceptable by improving training as well for staff to help them to manage situations. And the intention was to provide mental health support for staff who had been affected by specific incidents. And as a part of that strategy, there was also an intention to bring in national reporting of incidents like this. So in the 2024 NHS staff survey, which has recently been reported, 14.38%, they're all very precise figures when you look at them, 14.38% of those people who responded to that survey reported at least one incident of physical violence from patients or service users, sometimes relatives or others associated with them, in the previous 12 months, which is a pretty huge figure when you think about the number of contacts that occur in healthcare settings. There was an increase of 0.5% on 2023. So sadly, in spite of introduction of policies and strategies to try to reduce episodes of violence, it's actually increased in terms of what's been reported from the previous year. 25% of the responders to that survey reported having experienced harassment, bullying, or abuse from patients or service users. And in 2024, there was a published violence prevention and reduction standard, which had been updated. So it had previously been brought out, particularly with reference to trusts, in terms of various frameworks that can be used to consider episodes of violence, to record them, and try to approach how to deal with them. But the 2024 standard was updated to include recognition of the need to support smaller healthcare organisations, and including in that primary care. So while primary care organisations are not necessarily held to the standard specifically, there was an expectation to encourage primary care organisations to explore the standard and the benchmarks used, and use those indicators that were suitable to be implemented in terms of their local strategies. What constitutes workplace violence? And this is a question that we are often asked in terms of poor behaviour that's demonstrated by patients or their relatives, not uncommonly in primary care. So the Health and Safety Executive define any incident in which a person is abused, threatened, or assaulted in circumstances relating to their work. That can include both verbal abuse or threats, as well as actual physical attacks. And we often have contact from our members looking for advice for issues such as drafting statements for police reports, concerns about a conflict of interest when drafting a report and how much information they can share. Things like identifying people who have committed acts of violence or made threats, and whether it's okay to share what is basically confidential information in terms of reporting to the police. And we often also have a request for support and advice for our primary care members about whether they are in a position to remove a patient from a practice list and the steps that you have to go through in order to do that. And as we'll see, there are other strategies that can be put in place. It doesn't always have to mean off-listing someone if they have been challenging in their behaviour. But clearly where there has been specifically violence or significant threats, then that can lead to an immediate process of removing a patient from the list. And we're often asked about these sort of processes and how to go about implementing them in primary care. So some of the things that can increase the risk of violence and poor behaviour towards staff include particular situations that you might find yourself in as a staff member. For instance, working alone, so when there's no one else around, particularly if working outside of normal hours, possibly late in the evening for late surgery, or sometimes in the mornings prior to other staff members being in the primary care workplace setting at an early stage of the day. And also things like handling or having access to medication can be a concern and an increase in terms of risk. The kind of patient factors that might influence these difficult interactions can include, as you would expect, patients who have difficulties with emotional or mental instability, people who might be under the influence of drink or drugs, people who are just generally stressed and struggling. And I think that probably of the incidents that we hear about, that would constitute the majority, actually patients who are just finding it very difficult to navigate their healthcare or their illness and are feeling very stressed. But unfortunately, that comes out in their behaviour when they attend in the primary care setting. GPs are in fact more likely to experience direct verbal abuse than hospital doctors. And there was a BMA survey in 2022 in which 67% of GPs reported witnessing abuse towards colleagues from patients. And I don't think it will come as any great surprise to anyone to learn that 96% of those GPs said that that abuse was directed towards their reception staff. It's not really surprising that that's the situation. The reception staff are often the first line in terms of the people who are encountered in a surgery, either on telephone calls or in person when patients attend the surgery. And so unfortunately for them, they're often on the receiving end of some challenging behaviour and verbal abuse. In general, GPs reported that this type of behaviour has been perceived to be significantly worse since the pandemic. And I don't know what the specific reasons for that might be, but certainly if one looks in the media currently and on social commentary in local areas, but also more widely in the national media, there is a sense that when patients attend surgeries, for example, they perceive that the GPs may not be working because the waiting room is not particularly full of people. What they don't necessarily appreciate is the work that goes on behind the scenes when they can't see what's actually happening. Obviously, these levels of abuse cause increased levels of stress and burnout for staff, which in turn results in increased sickness absence and difficulties with retention and recruitment of staff to primary care, both clinicians and reception and admin support staff and managers. So it's clear that it's not just a case of it being an unpleasant experience when it happens. All of these events contribute to the difficulties in terms of primary care and the workload that our members we know are struggling with at times. So we know that from the recent survey from the Royal College of GPs, their statistics in April 2025, so this was just published last month, primary care staff delivered an absolutely astonishing 367.5 million appointments in 2024. That is just a phenomenal amount of work. And that had increased by over 17% since prior to the pandemic. So we know that everyone in primary care is actually working harder than ever and undertaking far more consultations than in the past. There were, in February of this year alone, over 23 million consultations. But unfortunately, what that Royal College of General Practitioners survey also revealed was that 40% of GPs reported feeling so stressed at work that they did not feel they could cope on at least one occasion per week. So very significant levels of stress amongst primary care staff. So unfortunately, even though there's an ever increasing demand and primary care keeps on delivering increasing numbers of contacts, it's associated with increasing levels of stress. So one of the questions we have to ask ourselves is, how long can that be sustained? Because workplace stress and difficult patients all increase the risks of staff choosing to leave primary care. So just going to talk about a case study now. And this is based on a number of cases that we see. These are very common issues that come our way for assistance in dealing with them. So this one relates to a patient who was registered at a GP surgery who, when they registered, the surgery were aware they'd already been removed from other local practice lists. The patient told the surgery that they had multiple health conditions and were under the care of numerous different secondary care services. And they reported that they themselves suffered from a disability due to their neurodiversity. As a result of their concerns regarding their disability, the patient requested that various adjustments be made by the practice. But unfortunately, over a period of time, the demands made by the patient escalated and reached a stage where they were simply unworkable. There were too many things that the patient wanted to be dealt with in multiple different areas, and it just wasn't possible anymore for a relatively small surgery to continue to provide the level of input that this patient demanded from them. In particular, there were daily emails which would contain a mixture of complaints and clinical concerns, questions about prescribing and referrals, and concerns raised about acute medical problems. The practice were doing their very best to respond to the complaints, but no sooner had one complaint been responded to than another one would be received, challenging the content of the previous response. And it reached a situation where there were hundreds of emails being received with complaints and increasing demands, despite the practice doing everything they could to address those. Then, just to add to the additional stress, a third party started to contact the surgery on behalf of the patient as well, which just increased the demands and requirements on the surgery. And the patient indicated that it was their intention to take some form of legal action on the basis of perceived discrimination due to their disability. So the practice had already sent a warning letter, highlighted the behaviour that they thought was unacceptable, and it hadn't resulted in a significant change. And so, on our advice, they considered a behavioural agreement and asking the patient to sign up to this. Behavioural agreement was drawn up, which set out the kind of behaviour that was considered unacceptable. And it asked the patient to modify their behaviour in terms of their contacts and their demands and the requests for particular management of how their information was shared and all sorts of other concerns regarding prescribing and contact with secondary care. And in fact, much to their surprise, the patient signed the behavioural agreement. And the behaviours improved significantly within about a week or two. But although their behaviour remained improved for a good period of about 3 months, unfortunately, after that, matters started to escalate again, and the patient received further warning. Because they'd signed up to the behavioural agreement and had then very clearly breached it and had been warned that they had breached the agreement, the practice was able to apply to have them removed from the list. And on making that application, interestingly, the position was very clear that they had done all that they could to try to manage the patient demands, and manage the behaviour. And so actually having them removed from the list at that point was not something that caused practice any great difficulty in terms of applying to have that removal put in place. Unfortunately, the patient continued contacting the practice after they'd been removed and was demanding to be re-registered. But the practice declined to re-register the patient and made multiple offers to assist them with registering at a different local practice, including providing them with lists of practices that had open lists for patient registration. And eventually the patient desisted, but it was a very long and drawn out process. But it goes to show how important it can be to follow the relevant guidelines in terms of issuing warnings, advising patients of the behaviour that is not deemed to be acceptable, and asking them to modify it. And a behavioural agreement can be an extremely useful tool. And if it's breached, it provides you with additional evidence as reasons for considering removing a patient from the practice list. So I'm going to hand over to John now, who's going to talk about another case. Thank you.
Thank you very much, Catherine. And also a reminder, well, actually, I don't think I said this at the start, but you can post questions in the Q&A about what we're talking about. We'll try to address those questions at the end of this webinar. And my understanding is if you post a question, nobody else sees it. So everybody's none the wiser of what you've asked, if that helps reassure you. So please do post your questions in there, and we'll try to get through as many of those as possible towards the end. But yeah, this second case study was or is based on an interesting case that is it's one of those days where everything seems to conspire against you as the doctor. So I think that the situation was in this case that there were IT problems and at the practice, and so the GP was already running late before she'd started her clinic, well, you can picture what was happening in the waiting room with increasing numbers of patients mounting up, and one becomes agitated about the waiting time. And there is a situation when the GP leaves her consultation room to see another colleague, and the patient approaches the GP and starts asking why she's running late. And all of this interaction was actually recorded on the practice's CCTV, and the GP declined to see the patient in the end, and the patient left the practice unseen. The GP explained that she felt threatened by the patient's behaviour, and then it resulted in the practice manager being involved, and who wrote to the patient to advise them that they would be removed from the practice list. And then the patient complained, and it was at that point that the GP at the practice wrote into the MDU to seek our advice on what they should do with the complaint. And I suppose it was a case that illustrated to me the importance of receptionists keeping an eye on what's going on in waiting rooms. I appreciate they have a lot of different things they're trying to do, but we've all worked with those receptionists who keep one eye on what's going on in the waiting room, and also answering phones and doing all of their other duties at the same time. I'm not sure how they do it, but there are those receptionists who we always like working with who seem to be able to do that very well. Actually, it transpired in this case that there was no message that to suggest that the GP was running late, and nobody had picked up on any particular signs that this patient was getting agitated, although it was clear in the CCTV footage that this patient had started to get up from their chair, they'd started to sort of pace around a bit, and so there was some behaviour there that suggested the patient was getting dissatisfied. And then we got to the point about the behaviour, and I think the GP felt threatened, and that's that was their feeling, and the practice took that seriously, which I think is important. I suppose the sort of disappointing thing was the patient left the practice unseen, and so potentially there was a missed opportunity there to get the patient seen by somebody else if they'd wanted to, and then we reached this position where the patient was removed rather quickly based on this particular interaction. And when I was able to view the CCTV footage, and the interaction, yes, there was certainly an interaction. There was the patient themselves was a big burly man, and the doctor was certainly smaller than they were, and there was a confrontation. But whether it warranted an immediate, well, it wasn't an immediate removal, but an eventual removal from the practice list, was a question that I suppose we started to reflect on with the member. And of course, in this case, the member was a salaried GP, so it was the organisation's decision about what happened to this particular patient. But certainly when I started to get more information about the sort of context to this patient, they'd had other episodes where they'd been threatening, or their behaviour had been perceived as threatening. But it was quite unfortunate that nobody had actually taken any steps previously, or certainly in the last 12 months, to warn the patient about that behaviour. And that would have probably stood the practice in good stead to issuing a second warning, or certainly thinking about removing the patient from the practice list when this latest episode took place. And so it sort of brings me nicely onto the second part of our webinar, which is looking at, I suppose, what we do with unreasonable behaviour before it reaches a breaking point. And that leads me onto this slide. And I've quoted there the GMC's Good Medical Practice, which says that you can only end a professional relationship with a patient when the breakdown of trust between you and the patient means you cannot provide good clinical care to them. And there is an emphasis on it being the last resort. And there is an onus on doctors, on practice managers, to be able to demonstrate that they've done what they can to restore the relationship, to get it back on track. And the GMC has guidance which is entitled "Ending Your Professional Relationship with a Patient," and I suppose it sets out some very clear definitions of a breakdown of trust. So violence, abuse, threats, criminal behaviour, acting in a sexual way towards you, and then persistent, unreasonable behaviour. So at one end of the spectrum, it's quite clear when there is that breakdown of trust. But then there is this sort of grey area of, well, what constitutes unreasonable behaviour? And I think it's sometimes those cases where our members experience difficulties in knowing exactly what to do, or what they can do. And what you want to be able to do is demonstrate that you have tried to get the relationship back on track. And I suppose you're also wanting to try and avoid that flashpoint or that straw that breaks the camel's back, where, a bit like in that case study, something happened which was just the final straw. But actually, if somebody takes a sort of slightly forensic review of what your decision making, what has happened in the past, have you got the evidence there to be able to um, uh, to justify your final decision on ending the relationship? So that's what a lot of our queries are. It's this sort of grey area about unreasonable behaviour. It's quite clear when, a patient has, I don't know, caused criminal damage to the practice property, that sort of behaviour, or made, certain threats to individual members of staff. And so what can help you in deciding what's unreasonable behavior and what you might need, what you should do? Um, certainly check your organization's policy. So if you're an employee, your organization is likely to have a policy on this, but also your local LMC will also have some guidance on it. Discussing it with colleagues is really important, and that's clearly very important if you're an employee. If you're a salaried GP or a locum GP working somewhere, you're going to be discussing it with the practice manager or the partner, and they're going to be involved. But also for the partners and practice managers amongst you, it's important to be able to demonstrate that you've discussed the unreasonable behaviour as an organisation, because that can help you to, when you're writing to a patient to warn them, that can help you to say to them, as an organisation, we have come to this conclusion. So you're not singling out anybody particular. The patient can't sort of pick on the practice manager or an individual doctor and say, it's unfair, this decision. It's you as an organisation have made that decision. And I also must stress, contacting us. I mean, that's what you pay your subscription for, is to obtain our advice on matters like this. And certainly if it's the first sort of sign of an unreasonable behaviour and you want some guidance on what to do, it might be very helpful to you to contact us earlier rather than later, for example. And members seek our advice on abusive behaviour, so verbal, written, physical, a misuse of service, so unreasonable demands. So a bit like Catherine's case study, sending multiple emails every day. I mean, that is unreasonable. You're providing a service to hundreds, thousands of patients, and in order to be able to provide that service, you're not going to be able to take the time to review an unreasonable amount of emails from one patient. So yes, some of the queries we get are about misuse of service, so unreasonable demands, threatening behaviour, damage to property. We also receive queries about derogatory social media posts and online reviews. And I would particularly say, do seek your advice on those sorts of things. And ultimately, the decision about what is unreasonable must be your organization's. And we can provide you with a steer in terms of helping you to think about the considerations. But that final decision is going to be your organization's decision. And you just need to be in the best position you can be to be able to justify it. For example, if the patient complains to your organisation, to the PCSE or the Ombudsman, for example, and if you've gathered evidence of demonstrating you've issued warnings, you've discussed it in a meeting together, and you've written to the patient to explain your reasons, then that can be really helpful in justifying that final decision, if you are coming to ending the relationship. And so I've drawn up this checklist. I've mentioned discuss it with colleagues. There is this emphasis on this responsibility on doctors to try and restore the professional relationship with their patients when it's becoming strained, and so it is important to highlight the problem to a patient and set expectations. It may be that your patient is slightly unaware of that they've got unrealistic expectations. Sometimes a meeting with the patient to set those expectations, to explain, it's not possible for us to provide the service we want to provide to all of our patients if you're emailing us 10 times a day. And also making it clear in perhaps in the meeting, but also any follow-up correspondence summarizing a meeting, that these are the ways we expect you to contact us. You've got all of these different ways to book an appointment, and the email address is to be used for this sort of thing. But also considering a warning. So sometimes I see cases where it's clear that, and the case study I talked about is perhaps an example of this, is where there are lots of little unreasonable episodes of unreasonable behavior, and unfortunately nobody has actually taken the step of warning the patient. And so, do use that, because most of you will have local guidance on the importance of issuing a warning on 2 occasions in the last 2 months in the last 12 months for the same behaviour, and that's usually what practices are expected to be doing, is issuing a warning, and then there's a second episode, and then thinking about whether you end the behaviour with the patient. Clearly there's some behaviour that requires the relationship to end sooner than that, but that's typically what you're dealing with. And also considering a behavioural contract. So I think there can be some trepidation in terms of setting this out. It's time consuming. Sometimes members are a bit unsure what to put in the contract, or what they can and can't put in the contract. And so do seek our advice on those. There are examples online of contracts. Your LMC may have examples for you, but it's something that it can be a good investment in time, considering the time it takes to deal with ending a relationship with a patient, and also dealing with their complaint about the relationship ending. So I think behavioural contracts can be very helpful. Of course, patients don't always agree to sign them, but at least you've shown that you want, by trying to get them to sign a behavioural contract, you're demonstrating there that you're trying to get the relationship back on track. Keeping good records of these steps is very important. And then when ending your relationship, explaining your reasons, citing the specific examples. So sometimes I read warning letters or ending relationship letters where they're not particularly specific about which behaviour has been the bad behaviour, and what's actually caused the warning, or the decision to off-list the patient. So making sure that you can keep those letters quite specific, I think, is important. And then providing information on how to challenge the decision, and details of the practice's complaints procedure. Also very important to put in that sort of correspondence. And this was going to be my final slide. And it's just to make you aware that the Ombudsman, so as you know, the Ombudsman deals with complaints that where a complainant remains dissatisfied with the local resolution, and they can complain to the ombudsman. But the ombudsman has this guide on managing challenging situations in complaint handling, and the ombudsman does say that any behaviour, so unreasonable or unacceptable behaviour in the complaints process, is any behaviour by a person that raises substantial health, safety, resource, or fairness issues for the people involved, either because of the type of behaviour or how often it happens. And we do see sometimes in complaints where you're trying to investigate a complaint that a patient has made, and then the next day that they're submitting something else, and then things start to get unreasonable in the amount or the frequency of their correspondence, or perhaps their expectations of the complaints process. So it might be worth, if you do have those sorts of cases, to have a look at this guidance. It's very broad, I would say, because it's sort of targeted at, is to be used to deal with lots of different situations, but it's certainly perhaps a good guide to have a look at if you're experiencing those problems. It may give you some things to consider, and of course, contacting us as well in those sorts of situations is really important, I think. So I think we'll go on to answering some questions. So I'm just going to get the question list up. I had looked at one, and Catherine's here as well, so she's been looking at the questions as well. I did see one question just before I started about behavioural contracts. I hope I've addressed it, but the person was also talking about the wording of a contract, and certainly we have cases where we look at the wording of a behavioural contract. We're happy to look through that. And yes, ultimately the decision is yours about what you're going to put in that contract. And as I said earlier, there are some examples of behavioural contracts online, and certainly your LMC may be able to give you some guidance on that as well.
There have been quite a few questions actually about behavioural contracts, and one of the things that has been asked, several people have asked, in the event that you try to get a patient to sign up to a behavioural contract, as in my case study, what happens if they don't sign it? And you did touch on that. It's really good evidence, if a patient hasn't signed it, that you as a practice have taken steps to try to work with the patient. And in terms of what you put in it, you want to be really specific about the behaviour that has led you to want to try to introduce a behavioural contract. Someone did also ask about whether we could change the name of a behavioural contract to call it something else. I mean, I think the words behavioural contract are pretty clear in terms of explaining and setting out for a patient that this is the behaviour you want them to sign up to, and to agree that they're not going to repeat those previous behaviours again. So I don't imagine that there's any problem with changing the name. You might want to call it something perhaps a little less confrontational if you felt that the words behavioural contract are a bit too challenging. But ultimately, it's about a good behaviour agreement. Effectively, you might consider a working agreement between the patient and the surgery. But there were quite a few questions about the behavioural contract. As John said, there are templates that you can use. You can find them online, and then you adapt them to use for a specific patient. So it's a sort of a generic base to start with, and then you set out what you want the patient to agree to and ask them if they're willing to sign up to it. They can be very powerful, but if they're not signed, that in itself can be good evidence of a patient who is not willing to amend their behaviour, and can then support you as a practice if ultimately you reach a stage where that patient has to be removed from the list. So it's just a bit on behavioural contracts.
Yeah. I hope we've answered those questions on contracts. Somebody else has also asked about sort of behaviour that goes unnoticed in telephone consultations. Of course, there are a lot of remote consultations going on at the moment, and I suppose there is a tendency, isn't there? If if you're going to take issue with abuse you're getting on the phone, that's going to probably make your telephone consultation last twice as long. And I suppose, is it worth it? I think it is, and for the reasons that I sort of said, otherwise it can reach a point where it's a flashpoint where somebody does something which is a sort of a slightly rash decision about deregistering the patient or something like that, and you haven't got all of those steps before then, which evidence how difficult it has been to deal with the patient's challenging behaviour. So, I mean, telephone calls, a lot of them are now recorded. I would encourage you to try to call out challenging behaviour, even in remote consultations, because it can help also your colleagues going forward as well, and hopefully, sometimes this also helps the patient to modify their behaviour before it reaches that breaking point.
Yeah, and I think you can follow up a difficult call, and someone mentioned abuse in triage contact by email, which is just not acceptable. So you can deal with the clinical issue, but then separate to any complaint process, you can draft a letter saying to a patient that this occasion, this behavior occurred, and setting out that it's unacceptable and that it's a formal warning. And there's no reason why you can't do that. You want to be mindful of keeping warning letters separate from complaint correspondence. So you don't want to bring up the poor behavior and try to address that if there's been a complaint in the complaint response. But it is really helpful to document episodes like that. And if you have patients who are repeat offenders, someone asked a question about general obnoxiousness and not necessarily swearing or specifically abusive. Again, what's important is collating evidence so that you can say that on multiple occasions, and you might keep list of dates. So if you have patients who are generally very rude, but not necessarily swearing and shouting, it's perfectly reasonable to say to staff, please keep a note. And then we can use that, we can collate that information, and we can write to a patient and say that on multiple occasions, and you can actually give dates and times and say, this is what was said, or this was behavior, and this was unacceptable, and we're writing to warn you about it. So definitely, ask staff if you have patients, because I think often we hear that staff know that there are some patients who are difficult and it's always going to be a challenge, and they come in and everyone thinks, oh no, not them again. There's never been one specific significant incident that meant that anyone could take immediate action. But if you haven't saved the evidence and made notes and kept details of those events, then it can be hard then to produce hard evidence. So keep a record if there are lower level things that are difficult, so that they can together formulate enough of a reason to consider a warning to a patient.
And sort of on the theme of documentation, somebody's asked about coding abusive patients. And certainly, I think if you have specific cases, I would always encourage you to seek advice from us, because these cases need to be considered individually. But in general, the idea of the clinical record, as you know, is to log the clinical information, but also to assist colleagues going forward in seeing that patient. So it should inform the patient's future care. So actually, if a patient has been abusive, physically abusive, for example, that may well be a necessary code to warn other staff members who may be seeing the patient, in the outside of sort of normal surgery hours on their own, for example. So there may be particular reasons why you do code. Of course, patients that now have access to that. Most patients have access to their records and can certainly request access. And so you want to. There is a balance there, isn't there, of coding for good reason. So I think I would encourage you to discuss those sorts of decisions and come to a decision as a group of colleagues, and also seeking advice on specific cases. Yeah.
And I think one last thing I would just mention, I think that we've had a few questions about managing family members who are abusive and rude, and that behaviour is still unacceptable, even if they're a family member who represents a patient. For instance, people have mentioned patients who lack capacity, patients where the relative has power of attorney for making healthcare decisions. Even if they're not registered as patients, it's not acceptable for them to behave in an abusive way. And I can't see any reason why you could not issue a warning to those individuals as well and explain that that's not okay. It's difficult because you don't really have a good enough reason to deregister patients themselves if it's family members who are being difficult. And someone also asked a question about where there's just one family member who's being problematic and there are other family members, and it's very clear you cannot deregister an entire family because one member of that family is being difficult. So you would have to be very clear to, for example, a parent of children, that even if you're off listing a parent, the children remain registered. But you would expect acceptable behaviour when they attend with those children, and that you would look to try to be clear about the fact that you're deregistering them but not the family members. That would potentially get you into some difficulties. So I think there are a lot of issues, and we do hear about these ones with family members who are very difficult. And I would again reiterate the earlier advice that each situation in those types of cases tends to be quite specific. So if you find yourself in that position, do write in and we can give you some more considered, specific advice to the situation.
And so someone's asked about patients with mental health problems, and I know we discussed earlier on. You discussed, Catherine, how that is one of the sort of risk areas, I suppose, in dealing with patients who might have untreated mental health problems, or certainly have a behaviour due to their mental health problems. I think when we consider those particular patients, I still think yes, you're going to make certain allowances for certain behaviour of patients, and often you, as the GPs, will know those patients well and what might cause a problem for them. There'll be particular patients where you just know that they can't really sit in the waiting room for more than 10 minutes. It's just not going to happen. And usually practices are very good at knowing what to do with those patients and sort of managing them. But certainly a mental health diagnosis is not necessarily an excuse for bad behavior. And there are many people with severe mental health problems who manage to follow expected behavior when they go into certain organizations. So I think sometimes we worry about that more than perhaps it is an issue, but also there are arrangements in place for patients who have very difficult behavior, and that might be related to mental health problems, and so there are those practices which have are set up to cater for those patients. And it may be that certain patients with mental health problems will be patients with behavior that you, as a practice, your particular practice doesn't have the facilities or the staffing to deal with, and so you may be going down that line of having to warn about behaviour and potentially off-listing the patient, and there being a recommendation that they get seen by a practice which is set up to deal with those kind of behaviours and those risks. Certainly not every practice is set up to be able to cater for that level of risk. So I'm just conscious we're approaching 8 o'clock, and I think we've answered certainly the majority of your questions. And I was wondering if my colleague Kate Muller wanted to come on the line and talk very briefly about the MDU's group care scheme. Hi, Kate.
Hi, thank you very
Thank
much Thank you very much to you both. Yes, so I'm Kate. I'm a GP liaison manager for the Midlands. And just really to take the opportunity to explain that this is something where the whole team can benefit. Group care is open to any practice where at least 50% of the doctors are MDU members. And we do actually offer a training session on dealing with challenging patients and managing confrontation for the whole team, which can be really helpful. One of the other benefits of group care is that we offer free membership for practice managers. And John mentioned that we do spend a lot of time helping practices when they need to draft responses to difficult patients or even draw up a behavioural agreement. So there's a whole host of things there. If you are interested, or even if you are a member of group care already and you would like to find out more about the training that's on offer or any of the other benefits, please do use the inquiry form, which you should see on your desktop, and you'll be able to, your local liaison manager will be able to contact you. And then just finally, I'm sure that many of you will have heard about Red Whale. We've partnered up with them. So if any of you have training practices where you've got registrars, please do encourage them to sign up to our free affiliate membership, because it gives them access to a lot of the Red Whale resources. And again, for any doctors that are due to qualify shortly this year, they can also benefit from a substantial discount, as well as the Red Whale Learning too. So with that, I shall say thank you very much to everybody for attending, and thank you very much for an excellent webinar.
Thank you, Kate. Yeah, so that's 1 minute to 8. I hope that that's been helpful in that you're able to take some points away as learning points, discuss them with your colleagues tomorrow. And I just want to say thank you for joining us. I know your time is precious, so I'll leave you all to get on with your evenings. Thank you.
Thank you very much.